Welcome everyone to Live Cases and Lecture 1, which is entitled TAVR Advanced Cases Learning. So I have the pleasure of moderating this session with Dr. Eberhard Grube, and we have an esteemed group of panelists, expert in structural heart as well. So Dr. Uno, Dr. Moon-Ki Hong, Dr. Jen Yi, Dr. Tay, and Dr. Lam. And so we have the pleasure that I think we have 2 cases this morning and then followed by 2 lectures. So without further delay, let's go ahead and go to Assam Medical Center. And I think the first operator here is Dr. S.J. Park. So S.J.?
First of all, I'm really happy to meet you all, my old friends, during the screen. I was really, hi, Eberhard, Myung-Ki Hong, Jay, really. Thank you, Dr. Tay, Lam, all right, good to see you all. All right, today we prepared 2 cases of TAVR. Actually, this first one is very interesting. It is combined congenital, secondary ASD and degenerative aortic stenosis. Anyways, so we're gonna do, our heart teams. Dr. Pyung Lee is to be the first operator for, the second ACE closure, and Dr. Lee Seung-ah from our Echo Lab, Professor Lee, Dr. Gang, and Dr. Lee Jung-hoon. So actually, we have very strong heart teams, and so Dr. Gang, would you, introduce the case first briefly?
Yes, the patient is a 79-year-old female and admitted for worsening dyspnea from a month ago. She had a history of syncope and diagnosed ASD, atrial septal defect, 10 years ago. And she underwent ECG and echocardiogram for evaluation, and her echocardiogram showed the severe degenerative AS and ASD. Next. Her STS-PROM score was 3.0%, a low risk of the cardiac surgery. Next. And ECG showed normal sinus rhythm. Next. And chest X-ray showed cardiomegaly with a small degree of the pulmonary edema. And echo showed severe AS with a peak and mean pressure gradient of aortic valve was 72 and 44 mmHg, and peak transaortic velocity was 4.4 meter per second. Next. And also TEE showed secondary ASD with a maximal diameter of 16 millimeter with the LI shunt. Next. We also checked the coronary angiography that showed normal angiogram. Next. And we also checked the cardiac cath that showed pulmonary vein resistance, pulmonary venous resistance 1.57 OD unit with a pulmonary artery pressure peak 27 and average 14 mmHg. And QPQS was 2.1 and cardiac index was 2.1 liter per minute per square meter. Next. So we decided to treat the AS and ASD in same time. So check the CT and TEE in depth. And this is a CT analysis of the aortic valve that showed annulus area of the 272 square millimeter, and the annulus area driven diameter was 18.6 millimeters. Next. And this is the shape of the sinus of Valsalva and ST junction. They show the large sinus of Valsalva area compared to annulus area. The sinus to annulus area ratio was 2.24. Next. And this is the landing zone of the TAVI valve, the LVOT. There was no severe calcification. And next. And this is the amount of the calcium. They show total amount of calcium was only 35 cubic millimeter and very low amount of calcification. Next. Yeah, as you see, the calcium amount is low. Next. And we also checked the coronary height. The left coronary height was a little bit low, 9.3 millimeter from annulus, but the sinus Valsalva size was large, and we do not so much concern about the coronary obstruction. Next. And this is the findings of the iliofemoral arteries, the approach site. because there was some calcification of the right femoral puncture site, we decided to puncture of the left common femoral artery. Next. And this is sizing chart for Sapiens 3. Because of the small amount of calcification, we decided to make oversize of the 15% to 20%. So we decided to treat with the Sapiens 3 20 millimeter. Next. This is the coplanar projection from the CT analysis. Next. So this is our TAVR planning. The Sapiens 3 with a 20 millimeter nominal to make 20% oversizing via left femoral artery for safe procedure. And we also already checked the coronary angiography. And we are checking the TEE imaging. Can you please show the TEE?
Yeah,
Okay.
I think
Really?
before just looking at the TE image, I think we have to, I would like to just briefly mention about the indication of AST in this procedure. Looking at the TTE, we had evidence of RV enlargement and paradoxical septal motion, which indicates a significant amount of left to right shunt and right heart volume overloading. And just reinforcing the indication of this procedure, we already did some the right heart cath, and if you look at the parameters, the ratio of QP/QS was 2.14, which is quite high, and peak systolic pulmonary arterial pressure was about 27, which is less than 50% of the peak systolic pressure of aorta. And PVR was 1.5. So this patient has a significant amount of left to right shunt via the secundum AST, and does not have a significant pulmonary hypertension, which is a good indication of AST, just considering that these parameter was measured under circumstances of severe aortic stenosis. So, just look, I would like to ask some to the panels if we have any concerns or technical consideration of this procedure, AST to do or not, or if we have to do the TAVI first or the AST first, something like that.
Anyone want to comment on about closing this ASD? It looks like there is a rim on both sides that technically should be doable. And the question, and there seems like enough of a shunt, right? You know, close to volume overload. The question is whether do you want to close it first or you want to close it, do it after your TAVR. So that's one. And second is that given this such a small annulus, I want to ask the panel, would they choose to do a 20 millimeter sapien or actually go with an Evolute here, because 20 millimeters always, I was always concerned with the 20 millimeter valve going in with a residual gradient. So any comments on that?
Can I make a quick comment?
Actually, I think it is some rare cases, the size of the annulus is very, very small. And please explain that why the simultaneous procedure for the ASD closure and the TAVI procedure at the same time. Personally, I prefer the ASD closure first, and then the stage, the TAVI procedure would be the more safe. Actually, during the TAVI procedure, the severe pulmonary hypertension is one of the risk for the adverse outcome. So personally, I prefer the separate the procedure, the fixation of the ASD first, and then maybe several days later in the TAVI procedure.
Okay.
Sure.
Can I give you a quick comment?
Yes, please.
I agree that this ASD is hemodynamically significant, so I would go for closure as well. But obviously, the prognostic impact is higher for severe AS. So, and this case, pulmonary artery pressure is within normal limits. So I would go for TAVI first with Evolute 23 millimeter valve, as mentioned that it gives hemodynamically superiority. So, and then afterwards, as a staged procedure, I would go for ASD closure.
Okay, we have lots of debates here. I don't think we have a definite kind of answer, but I think that all the panelists agree with that this patient has a definite indication for ASD closure. So we would like to look at the TE image right now for looking at the technical feasibility of ASD procedure. Professor Sung Lee, please.
Okay, you can see the 3D image here, and we can see the insufficient aortic limb here, but the size is really feasible to fix the ASD closure with device. And we can see the secondum ASD here, and through the ASD, we can see the delivery sheath here. And I think the device closer is a really good choice for this.
Okay, so we have a relatively short out aortic rim, which is not good for percutaneous closure. But if you look at the key image, we have a aneurysm change of septum and some hypermobility of the septum at the posterior limb. But actually, this ASD is oval shaped ASD. The longest diameter is 17 millimeters, and the short one is 8 millimeter, and the other rims are relatively good and stable. So we thought that we won't have some significant considerable issue in the closing of ASD in this procedure. So we want to just introduce our own sizing algorithm. Recently, for about 5 or 6 years, we do not do balloon sizing for any ASD procedures in our center. We actually use our own sizing algorithm, which was developed with from our team. Right. And Dr. Sung will just introduce our algorithm.
Yeah, we
slide, please.
We took the echocardiography with the 3D image on the left side, and we make the multiplanning image for measurement of the maximal size and minimal size of the defect. And middle image showed the maximal size of the defect, and we can see the smallest diameter like this. And we already reported that the equation of this is really feasible for measure the real size of the defects. So we always choose the defect size like this. So this patient have ovoid shape of the ASD, and the maximum size is 17 millimeter, but we can choose the 18 millimeter because the shape is ovoid. So we choose more the maximum more size of the 18 millimeter. The device can be not fully wrapped.
Okay, so according to this algorithm, we select the Fibula Flex 18 millimeter device, and we're going to do the device closure under TE guidance.
Mm-hmm.
Okay.
Can I just make a short comment?
Yeah.
I think I agree with Yohei's comment that some of us would separate the closure from the TAVR procedure. And one of the main reasons we do that is because in patients with severe AS, the left atrial pressure in these patients typically are elevated.
Yeah.
And if you close the ASD, some patients may actually feel this increase in left atrial pressure the minute the procedure is done. And sometimes they feel a little bit short of breath. So typically what we would do is we would do the TAVR first, give it some time for LV remodeling to occur. The LV pressure will drop over time. And then afterwards, we may actually do a balloon occlusion and then measure the LV pressures and then see how the patient's LV pressure is. Because in some patients, if the LV pressure remains very high, you may have to even sometimes occasionally fenestrate the ASD so they don't feel so symptomatic. So this is just something that we sometimes do in older patients.
Yes, right. So I already mentioned that these parameters were measured under circumstance of the presence of aortic stenosis. So just fixing the aortic stenosis, the hemodynamic parameter would change. So academically, that the process that you told us, it would be ideal, but practically, this patient is a very old woman, and it would be very impractical to just get this patient back on the table when she really has a continued indication of ASD closure. So that was our consideration. Thank you for your comment.
While you're doing the case, how high was the left atrial pressure? Sorry, when you actually, did you measure it with this?
We measured the wedge pressure already.
Yes.
Can you show
the
us?
direct LA pressure, you could have measured that,
Right.
but maybe you did not. Yeah.
Yeah, we did not. Sorry.
Okay. Go ahead.
Okay. There's a figular 18 millimeters. You can see the T there.
Yeah. Pull back more.
Okay.
Okay, stay here. Okay. Oh, no.
No.
Yeah.
All right.
Can you please show the pressure curve? You're checking the continuous
Pull back
pressure.
more.
More. Here.
Okay, and the septum is a little bit unusual change.
All right.
So,
right
yeah,
here.
you can.
How about here?
Okay.
Okay. So we all know that the figular devices has a bulb type attachment. So the morphology of the device will not change before and after the detachment of the cable. So I think this morphology is relatively good. I would do a little bit of wiggling to find out whether it's stable.
But you can see, we can see a little bit defect and the shunt floor here, but I think after deployment, it will be gone.
Okay. Okay.
Good.
So,
Okay, so
would it be
wiggling,
good?
please.
Okay, I will release the
Okay.
cable here. Okay.
I think it's stable. Very good.
All right. So our next step will be to do the TAVR very safely, right? Okay.
Are you finished? All right. All right. Great. Great procedure. All right. So we have some debate concern about the simultaneous procedure for ASD closure, device closure, and TAVR procedures. However, simply technical aspect, the morphological concern is very easy to do procedures. Even aortic stenosis is quite a small amount of calcium. We didn't do the pre-dilation too. So technical aspect, we're gonna do. We have decided simultaneous procedure would be okay. And Dr. Lee has a lot of experience about device closure. So we have already got some feeling. It's not so difficult procedures. So right. So ASD closure is okay, and so we're gonna do TAVR procedures. We have very limited time, and so we have already placed PCAL in LV. All right, wires.
So what wires do you use now, SJ, for
Wire.
safety valve?
Safari wire.
Safari. Yep.
Actually, the CT measuring the left coronary, the height is the less than 10. In kind of cases, do you usually prophylactically protection of the left coronary ostium during the procedure or not?
All right, great. Let's comment about that. However, particularly these patients, actually the sinus ratio in terms of, sinus is very big compared to the average, ratio, almost 2.24 something. And so even the height of left coronary, ostium is lower. So in particular, this case is big sinus ratio, so we didn't too much concern. About the, okay, so we want to do direct,
without the protection.
All right.
And the second one is we have to consider that the severity of the calcium in the valve what I mean is that during the deploy of the valve, particularly in the SAPIEN valve, main cause of the coronary obstruction is a migration toward the arcing of the left coronary ostium. So the severity of the calcium should be considered. In these cases, the severity of calcium is not so much. Maybe the prophylactic coronary protection is not needed.
No, you have to say that. Oh, no. Susan. All right. Push a little bit, behind the device. However, I think it's very soft valve, and so I didn't do hesitate. Why? And all right. Contrast, please. Okay. Good. Test. Okay, still outside. I think it's okay. Good.
Push, you need to come back here.
All right, push out to this point. Okay, test please. All right, a little bit further. Oh, it's nice. Sound a little bit modified with LV wires. Test please. Okay. LV wire, kept LV wires. I'd like to push in a little bit further. Test. Other thing.
It's good.
It's okay. Maybe a little deep. So careful. Yeah.
Test.
It's good.
Okay, gonna do. Ready, pacing. Okay, contrast. 충분히 주세요. Okay, inflate.
Inflate.
Good. 1, 2, 3, 4, 5. Deflate.
Inflation.
Okay. And device out. We choose anyway 20 millimeters, 20 size of SAPIEN 3. It's area of size almost 20%. At the beginning of our procedures, you mentioned about compare with evolve and things. However, still, I prefer practical procedure for SAPIEN 3. So, all right, let's a little bit further pull the wire out and pigtail a little bit. Okay. What do you think? Purposely?
I think, I think the procedure is really good, but you can see the AR mild, but it is a valvular AR. So when back through the wire, and then
Great.
I will have to check the AR again.
All right. So esophageal transesophageal echo clearly showed wire related maybe. All right. I would check the air to run here. All right. Injection contrast, please.
So let's put it in a pigtail. Let's see the wire is too stiff and pinning down a leaf.
All right.
Okay, right. So
All right. So exactly the AR is mainly related, or wire related. I believe so. So less calcium, enough, sinus ratio in terms of area ratio 20%. So we didn't anymore. All right. So why not pull the out device wire in.
And also, we would like to see the simultaneous pressure measurement.
All right.
Yes.
Wires.
Personally, I think is that the technique itself is the excellent and the perfect, but in the clinical aspect, actually the patient size is very small. The height is 138 and the body weight is only 40, and therefore you have to choose the very small size of the sapien valve. There is the image specialist. I'd like to ask what is the effective orifice area after the TAVI procedure in this patient. It is able to measure in the on-site. Please provide what is the effective orifice area after the sapien 320.
But you know, I think what we see here is something that is probably doable in an old patient. In a younger patient, I would agree. I would not put a 20 S3 into a younger patient.
Okay, would you show us the pressure monitoring on the screen? Okay, great.
With an old.
No gradient, most. Yeah.
All right. Maybe
Yeah,
some.
the gradient is okay. It's.
All right.
I think it's totally reasonable in an 80-year-old to do that.
All right, great. However, still some dots.
Yeah.
Tip.
Can you please show the T?
I want to
check.
The valvular opening is really good, and there's no palpable leakage and AR.
Okay, great.
Well, you
Very
know, can we still do an angiogram? Because we did.
Before the pullback, the picture wires, I'd like to do electrogram first. All right, ready? Okay.
Yes, ready.
All right. Injection. Well, still some AR. However, I didn't do any more
Just take the
procedures.
pigtail out at this point and just check. Yeah. Exactly.
Wire. All right, good.
Check it
So,
again.
all right, echo. All right, monitoring first. One more.
Okay.
Professor Lee. No pigtail cut. Stay in LB on Fury.
I think the position is really good,
All right.
and the opening is quite excellent. And I think the very small, I think no palpable leakage here.
No PBL.
Yeah,
Right.
very good.
Great.
I agree.
All right. Yeah. So I want to do a final. Anyways, electrogram again. All right. Quite acceptable for 30 millimolars and
Trace, yeah.
total. Are you? I want to show, no AR in this audio view. Actually, contrast again. All right. However, I don't, too much concern about that one. All right. Honestly, complex anatomies, combine the secondary, ASD, secondary ASD, something like that. However, procedure-wise, as Dr. Lee is really expert for the device closure, so we do lots of experience about, TAVR procedure, and so we do not hesitate, simultaneous procedure for a particular patient. All right, any comment on that one?
No, I think it's very well done, SJ and team. The question still remains to do TAVR first and then followed by ASD or this way. I think you showed it beautifully and with an excellent result, and patient is taken care of. I think that's excellent.
All right, thank you. So we want to move second collapse. We want to show some another interesting cases though. All right, thank you for discussion.
Hi, John Wook, Alan Young, and also Eberhard Grube with a panelist, all the panelists that you know.
Okay, so, thank you.
Let's go ahead and present.
Okay, thank you for joining the 2021 AFib Valve Structural Heart virtual meeting. And I'm very pleased to see you, all the friends, Eberhard, Alan, and the Professor M.K. Hong, and the Mao, Yohei, Edgar Tay, and Jenny. I'm going to start to introduce our team. My name is D.W. Park in Asa Medical Center. I will join this live case with the foreigner fellow And Dr. Dr. Go from Japan, he's spent 4 years. He's really expert in TAVR procedure. Another fellow from Dr. Gosadi from Saudi Arabia. Okay, Dr. Go,
Yes.
can you explain the patient background?
Yes, thank you. The patient is a 74 years old female, was referred to our center for treatment of severe aortic stenosis, and she had resting dyspnea 2 months ago and admitted to local another hospital for acute decompensated heart failure. Her echocardiography showed the severe degenerative AS with a reduced ejection fraction. The symptom is a dyspnea NYHA function 3 to 4. And next. Her medical history contains hypertension and hypothyroidism. On the admission examination, the thyroid function is normal right now, and the STS score is elevated up to 5.8%. And this patient is also frail. The height is just only the 160 centimeter, and the weight is 40 kilogram. And next, EKG showing the normal sinus lesion. And next. X-ray showing the cardiomegaly, and next. So as you can see, ejection fraction is reduced down to 27%, and the mean pressure gradient at 42 millimeter mercury, and the peak velocity is 4.4 meter per sec. And next. This is the annulus measurement. Annulus short diameter, long diameter is 24.6 and 27.7 millimeter. Annulus perimeter is 83.9 millimeter, and the annulus area is 547 millimeter square. And next. So what we focus on this slide is the ratio between sinus of Valsalva and annulus, and also SC junction and annulus. The ratio in sinus of Valsalva relative to annulus is 1.53, and in SC junction the ratio is 1.26, meaning that this patient got the relatively smaller sinus of Valsalva in the SC junction. And next. This is LVOT, it doesn't have any calcification. Next. The total amount of leaflet calcification is 503 cubic millimeter, so severer than the average. Then next. This is a longitudinal analysis of the distribution of calcium. Calcium is not extended to LVOT. And next. So coronary height is very low, 10.6 mm, and the right coronary is 15.8 millimeter. On the left picture, we simulated a virtual valve, which has 10% oversizing relative to annulus. And the virtual valve to coronary distance is just only 2.2 millimeter, meaning that this patient got a higher possibility for coronary obstruction. And next. This is just only notification for the operator. This patient got the apex thinning, so just caution for when you are in the LV wiring. And next. So peripheral is large enough for delivery. And next. So today, this patient got a very low ejection fraction and the frail, and we don't want to do the rapid pacing. So to avoid that, we have chosen the Evolut Pro. And according to the sizing chart, usually the target oversizing in our center is 20 to 30% perimeter oversizing. So our Evolut R34 should be the suitable. And next. And next. So this is a specification of the Evolut R. The inner skirt height is 14 millimeter, so higher than the coronary height. So we discussed about the implantation depth with Professor D.W. Park, and relatively now the trend is high implantation, but we try to avoid the coronary obstruction. So a little bit deeper implantation is planning.
Okay, could you go back the coronary height view? So if I'm gonna briefly summarize it, this patient is age is a 74-year-old female. Age is relatively intermediate. However, she has a lot of some risk factor. BMI is just 15. Is a fragile patient. Ejection fraction was 24. Anatomically challenging portion is the sinus of Valsalva was narrow compared to usually 1.89. This patient just 1.5. Also, coronary height is less than 10. It looks like a left coronary height of 10. If you consider length of left coronary cursive is 13, there is some overlapped coronary ostium. Also, we know where the VTC virtual, the transcatheter valve, and the coronary distance less than 4 was a well-known risk factor, the coronary obstruction, but this patient is 2.2. So there are many risk factors, and the coronary obstruction risk, narrow sinus, ejection fraction is low. So there are many debate portion which valve would be selected, and the Alan is ending this live case demonstration shows which situation, which valve would be more suitable. Also, we will show them some technique using the self-expandable valve system. Also, any comment or thought until this presentation?
Yes, John Wilk, so challenging case with the effaced sinuses, and the question is whether you would protect the left main at this point. Looking at the picture on the lower left, there's really a tube-like sinus, as it sort of go up to the as the outflow and so forth. So it'd be interesting to hear the commentators and what would they do in this case. 34 is large as well, so that also could potentially be an issue, even though your sizing is what you want, but whether you consider a smaller Evolut Pro as well. So Eberhard?
Yeah, I think that's definitely a more challenging case here, not only as far as calcium is concerned, but also coronary, the small sinuses, it looks tube-like. Question is whether you use a 34 or 29. And even though you have a low ejection fraction, one thing if you don't want to do protection, regardless, I think it would not, it would help to place a wire there, or to do, ballooning in order to see what the leaflet is doing when you balloon it, in order to have some way of considering go ahead with no protection or no stenting. I think the question is still open. 34, 29. I'm not sure whether the jury is still here on this case. I think they decide on 34 as 20% oversized. So this is going to be a very interesting case, and many things could be said about this. But I personally would probably not use the 34. I would probably pre-dilate, not as a pre-dilatation, but to see what the leaflet is doing with regards to the ostium, and then decide how to move.
Yes, very nice comment.
Any
comment?
Sorry.
Okay.
So I would also do a balloon to test the coronary obstruction risk. But may I ask, Secretary, what size of balloon you will use? You want a match size balloon, just like you use. If you're going to put a 29 sapien, you may use a 25. But if you're going to implant the evolut, I may choose the balloon that match the minimal diameter. But that minimal diameter with that size of balloon, we can not really test the occlusion, because it doesn't push to the very end to cause occlusion. So
I think it's a very valid point that you're raising, because that actually also might help in choosing 29 versus 34. If you use a balloon and you see the amount of sealing and the amount of AR might bring you a little bit more towards 29 or 34. I think that's a valid point.
Yes, and with contrast injection during the ballooning.
Right.
Yes. So what about the choice of the Safin versus Evolut, is balloon expandable versus self-expandable, such a low ejection fraction, low coronary height? What is the expert comment on that?
So my little comment is, because eventually I need very pacing, no matter it's for the balloon sizing or for the balloon implant. Then for the LV impairment, it don't affect my decision too much. So I may choose a 29 sapien with reduced volume. But I think for 34 evolut, I a little bit worried about the eventually the stent will actually face together with the aorta. Then I personally may think there may be some risk of delay obstruction that I need to worry overnight. But then I think, but overall, I think both valves should be good, and I would test with the balloon first. Flow threshold for coronary protection, and it really a difficult decision.
Yeah.
Can I comment?
Yes, please.
Okay,
Great.
Hi. I know you don't have that valve. If at our center, I would do the J valve. This is definitely the moderate risk for the coronary obstruction, and J valve will be perfect for this situation. But I agree, if you choose Evolut Pro, this I think I would prefer choose a small one after balloon rather than oversized too big. And I do have a little sapien valve sometimes not a better choice in this kind of situation. The reason is because you use Evolut, usually you oversize more, and the sapien actually you don't really need too much oversize. So in this kind of situation, sometimes the sapien actually probably is less risk for coronary obstruction in this kind of situation. So I agree, is a balloon probably is a good idea with the contrast to look at the left main, but eyes of valve, I think EF are not too concerned about the pacing for the 20-some%. I don't think a really major issue.
Okay, so could you show us the simultaneous pressure monitoring? Okay, looking at the simultaneous pressure monitoring is you can easily recognize how much severe AS pressure gradient. So, and to save the time, I'm gonna procedure. So we already decide to put the Evolut system 34, and usually in our algorithm, if you're gonna select Evolut system, we prefer the more than 15% parameter oversizing. Yes. So less than 15%, there are some concern of the significance of PVL on the basis of our previous experience. So at this point, if you select the Evolut system, we are considered this is peripheral is a 5.4, and the Evolut 34, the minimum requirement is 5.5. We're gonna use the inline sheath. Also, the how much implant, the depth would be one of the concern. We already put the coronary protection. This is the jockey, and then put the non-compliant balloon 3.5, put the coronary system to protect. So,
what is your implant technique? What's your implant technique? Are you using the coplanar or the cut overlay?
Yeah, so we're gonna use the two type of the techniques. So this is the small sapphire wire. Okay. And then remove the sheath, and then we're gonna change it, the inline sheath. So if you consider nowadays, and Eberhard will talk about the low implant technique is a causative overlap view. Nowadays, there is a booming in the implant technique to reduce the risk of the PPI. So I'm gonna explain how do we use the tricuspid view and the causative overlap view. Okay. Okay, got it. So, Evolut R system and the height of the inner skirt in the suture line is 14. So, and the coronary height, this patient is 10. So if you consider of the height and the node 0 and node 1, that is the 6 millimeter. And so if you're gonna put the, insert over here. Okay, insert over here. So if you want to put at least more than node 1, yes, we make sure the inner skirt is 14. If you're going to put the node 1, there is a 6 millimeter. Yes, we have the 8 millimeter height from annulus to coronary height. Yes. So usually the low implant technique is causative overlap view. We started just the 3 and 4 with in-depth. So there is so we're going to do slightly more deeper implantation. Yes. Okay, initially to prevent coronary obstruction, there are important two parts, and the flushing port is 3 o'clock, and then the hand marker should be great curvature. Okay, tricuspid. Okay, Denmark.
So,
그래서
Yohai, could you comment also from your point of view how you would implant it, which technique you do?
Sure. The dilemma of this
is
specific
great.
case is that if you want to prevent coronary
됐다.
obstruction, you want to implant a little bit deeper. While using this 34 Evolute R with significant oversizing is, I'm concerned about the conduction disturbance. So I would choose 29 in this specific borderline case due to small sinus of valsalva. And I would prefer simple procedures. So I would personally go for a little smaller valve without coronary protection if possible.
Okay, this is cursive overlap view. As you know, in the compared to double S technique view, tricuspid view, cursive overlap view usually more caudal and more RAO view. And so, this point is the pigtail tip was located in the NCC. Usually, if you're gonna do cursive overlap view, we're gonna release at the middle part of the pigtail ring. So, but however, this patient, we're gonna do more deeper implantation. We're gonna try to the bottom of the pigtail, and then over there is released.
오버래핑 뷰로 가겠습니다.
네, 오케이. 오버래핑 뷰.
많이 가야 됩니다, 선생님. 40에 40입니다, 선생님. 오케이. 되도록 맞추겠습니다. 됐습니다, 선생님.
됐죠?
네.
This is a cursive overlap view. 야, 이게 손이 안 나온다. 으쌰. 됐다. 그죠?
예.
자, 그냥 할게.
네.
자, 여기서 준비됐죠?
네, 준비됐습니다.
자, 테스트. 오케이. 자, 여기서 조금 여기서부터 풀어볼게요.
So normally, cut overlap will you be releasing the band at the middle part of the
pacing.
patient,
A
little longer.
120. Okay. Release.
You go a little lower.
Release. Okay. This is possible. 자, 천천히 테스트. 오케이. 자, release. 오케이. 혈압 떨어지면 얘기해줘. release. 자, 테스트. 오케이. 자, release. 천천히. 오케이. release. 오케이. 혈압 떨어지면 얘기해줘. 자, 테스트.
지금 조금 떨어집니다.
자, 펴보세요. 자,
올라옵니다.
오케이. 조금 깊은 것 같아. 잠깐만. 오케이. We're gonna check it up. 잎이 올라가고 있죠?
유의되고 있습니다. 올라온다.
오케이. 그 다음에 트라이커스피드 한번 가볼까?
템퍼리 좀 오프.
네, temporal off. 오케이. This 120 control. 오케이. 우리 그 트라이커스피드 한번 가볼까?
편안한 뷰로
다른 뷰로 한번 해서.
네, 선생님.
I think slightly some differ. 여기 요건가?
네, 여기입니다, 선생님.
오케이. 자, 보자. 자, 테스트. 깊지? 자, 그러면은 다시 감았다가.
네.
오케이.
됐습니다, 선생님.
I think it's more deeper and
Does it feel like too deep on the left side?
yes.
예, 올라왔습니다, 선생님.
됐지? 혈압 올라왔지? 오케이. 됐지? 오케이. 다시 카우치 오브레프로 가서.
네, 파세오로 가겠습니다, 선생님.
Dr. Va, please keep in mind that the ejection fraction is low, so the excellent maintenance of the hemodynamic status and the quick procedure is more essential.
Definitely. 자, 한번 테스트. 자, 여기 커스 오브레프야. 자, 여기서 자, 120 패싱. 오케이. 자, 한번 릴리스 천천히 릴리스. 천천히 테스트. 오케이, 릴리스. 자, 천천히. 자, 테스트. 자, 릴리스. 오케이, 릴리스.
혈압 조금 떨어집니다.
오케이, 릴리스. 오케이, 릴리스.
올라갑니다.
오케이, 올라가죠?
네.
자, 트라이커스피드 뷰.
선생님.
And stop the pacing.
네, 올라갔습니다.
나쁘지 않다. 자,
네.
오케이. Blood pressure is okay.
네.
Diastolic press is going up. 오케이, 이 코로나리 한번 살짝 찍어볼까요? obstruction 리스크 어떤지 보게. Okay. So, and this patient is concern is not PPI. This is coronary obstruction is major concern. Okay, test. Okay, coronary obstruction is looks okay. 이거지? 잠깐만. 자, 여기서 한번 찍어볼게. coronary obstruction. 자, 준비됐지?
네, 됐습니다.
자, 풀샷. You know, so as you see, the coronary ostium is okay. 자, pigtail 한번 여기서 찍어볼게.
네, 선생님.
자, 풀샷. 한번 에코를 한번 봐주시겠어요?
네.
PT를.
Considering the hemodynamic status, I think this position is reasonable.
Yeah,
for the-
yeah, I think so. Yeah. Okay, the special echocardiographer and check it up.
There's no regional wall motion abnormality,
Okay.
but the contractility is not so good. But I think the baseline is the same contractility.
Could you check it up? How much PVR?
Okay.
I think the left side will pull up once you release it. It will go towards the other side. So it'll probably come up a little bit. It'll probably be okay. It's hard to know for sure the coronary obstruction yet because you know the valve obviously is not open up that location too much. And I don't recall how thick the left cusp is, whether there is any. It's hard to see on this view, but it doesn't look like there was a lot of calcium, a ball of calcium, which is sometimes a risk that you cannot tell too well, and when it slams up and actually blocks off the left main. So I think the leaflet were not particularly thick or nodular, so that's good. But I think the protection should continue for now.
Okay, Dr. Lee, how do you think the amount of the PVR?
Okay, I will check it.
Yes. So diastolic pressure is now 70.
Please show us the hemodynamics.
Yes. Okay, got it. 거기 잘 안 보여요?
예, 윈도우가 전
윈도우가 좋지 않아? PVR은 뭐 다이스톨릭 봐서는 괜찮아 보이는데 잘 안 보인다는 얘기죠?
So we can see the three-chamber view like
Yes.
this, and yeah, there's no significant AR here. But okay.
Okay, got it.
On the posterior side, I think the grade 2 AR here.
Okay, got it. So, but I think this position is not bad. So, okay, 여기서 한번 다시 테스트를 좀 해볼게요. 요 에코 좀 잠깐만 빼주시겠어요? And slightly deeper, and considering the patient hemodynamics and the coronary height, 아니 그냥 the tricuspid 한번 가볼까? View and this position would be the best option for that. 자, 한번 테스트 한번 해봐. 오케이, 자 여기서 풀어보자. 자, 풀어볼게. 자, release. Okay, tension release. Okay. Okay, I'm gonna do tension release. Okay, got it. Tension release.
I'm gonna go it slowly.
Slowly, and the tension release. Okay, tension release. And push it up, and the wire slightly pull back, and the tension release. Okay, tension release. Okay, not yet. Okay. 더 풀어보세요. Okay, got it. Okay. Okay, 다 풀었다, 그치? Okay, and then we're gonna measure the simultaneous flow hemodynamics, and at this moment, it's very careful to pull back the valve. Okay, got it. Here. 자, 주문 풀고 여기 내려와서 이거 다시 한번 붙이고, and then we simultaneously check it up. The AP로 놔두고, status. 자, 요거 이제 붙이고.
예, 알겠습니다.
그러고 나서 바로 빼고.
시스 준비했어요.
시스. 준비됐죠?
네.
자, 뺀다. 자, okay. And then the measurement and the simultaneously. Okay, got it. Okay, got it. sheath. And then we're gonna measure the simultaneous pressure monitoring, how much significant. Okay, 이제 들어갑니다. 밑에 돌리고, yes, okay, got it. 볼게요. 하나, 둘, 셋. 하나, 둘, 셋. 1, 2, 3. 1, 2, 3. 1, 2, 3. yes, flush하고 피부테를 줘보세요.
What size sheet you put in, don't work?
This is the 16 French and the sheath. Yes. Okay, for Evolut 34. And then we're gonna put the soft pigtail and then measures pressure simultaneously, and then as well as echocardiography. Okay, 잡았지? 이거 하고. Okay, got it. And then 우리 저기 그거 주고 소프트 와이어, 테르모 와이어, 풀백. Okay, got it.
I think the 3 AR, grade 3 AR, so the amount is moderate.
We want to show that the hemodynamic simultaneous monitoring.
Okay, great. 자, 됐다. 요거 프레셔를 요걸 연결해야지. 오케이, 플러시.
제로인.
제로잉하고 요거 좀 닦아줄까? 피가 뭐.
이게 L구랑 R사, 빨간색이랑 녹색.
자, zeroing and then check it up the pressure, the simultaneously pressure monitoring. Okay, 됐다. And then check it up the final angel. Okay, that's it.
Personally, I think the procedure itself is excellent and a very educational demonstration. And before that, actually, this patient is a combined.
So, and can you see the
function?
Okay, can you see the flow, the simultaneous pressure monitoring?
Yes.
Okay, so I think AR index more than the 330, and there was some simultaneous pressure monitoring, and there is some mild and almost moderate AR index would be okay. So I'm gonna check it up, the final angel. 잠깐만요. 자, 이거 파이널 좀 찍고 요거 빼고 잠깐만요. 자, 요거 빼고 다 뺀 다음에 한번 볼게요. 그럼 요거 자, 바이 contrast하고 coronary status. I'm gonna check it up first, coronary status, and then check it up the valve status. 자, coronary는 됐죠? 오케이, 테스트. 오케이, 엔진 한번 찍어볼게요. 이렇게 해놓고. I think space is okay. 자, 좀 내리고.
프라임 갈까요?
좀 큰일 날라. 좀 더 잘 보이게. 오케이. 오케이, got it. Angel ready?
Ready?
Full shot. So coronary ostium is okay. So we have no further concern of the coronary ostium. Pull back the wire. 오케이, 이렇게 해놓고 이제 저기 봅시다. 코플라나 뷰. I'm gonna check it up the final angel. 좀 여기 가려서 그런 거지. 나 조금만 더 뺄게. 오케이, 됐지?
네, 됐습니다, 선생님.
자, 준비됐나?
네, 선생님.
오케이, 엔조.
네.
자, 풀샷. So I think the result is acceptable. Yes, 또 아래 뷰로 한 번 더 가볼까? 네. 오케이. 자, 됐지? 자, 됐다. 오케이.
맞추겠습니다, 선생님.
엔조 ready?
Ready?
자, 풀샷. Good. So I think as usual case, the depth of implant much differ. We concern about the coronary ostium obstruction, but the final angiogram result is acceptable. Just almost moderate or less than I think it's a mild PVL. and the pressure monitoring is AR index more than 3.0. So I think in this case we have a lot of things concerned, and real daily type of practice. There are many complex situations. This case give a lot of educational point. So, and I'm gonna share some nice comment from expert.
I agree. This is a really educational cases, and the procedure itself is the excellent, and is one of the interesting findings that the good cases for the selection of the evolutor, in this cases low LV function and the protection of the left coronary artery, and the engagement. The TAVR procedure was completely done during an engagement of the caster, and the pullback is safely done. The one of the question is do you expect that the reduced LV function is recovered after the TAVR valve is only 29 and will be recovered? And the second one is the
Yes, so and easily, and we are recently published how much ejection fraction, the impact of a prognosis in the American Journal of Cardiology, and 1/3 is immediately going up the 1 or 2 days later, and the ejection fraction much improved. I hope that this patient is much improved, and some patient in the slow gradual increase of the ejection fraction is that article would be shows what is predicted of the ejection fraction improvement. Yes.
One of the impressive finding after the TAVR procedure is that the pressure monitoring over the left ventricle is LV and diastolic pressure was 15. It's a very excellent result.
Yeah. Thank you.
Now, I think don't look at it illustrates, when you have a plan, you don't have to listen to the panelists. No, we always tell you to use a smaller one, this and that, and this looks excellent. And
so if I'm going to select the smaller one, there will be much people. Yeah.
Because you look at all the question about selecting valves and doing the procedures, knowing the details. You kind of measure everything, you know where the gap is, and this 34 actually turns out that there's a pretty good weight in that location where the coronaries are. So it actually pulls away a little bit. So a very good pre-procedure planning that sometimes in these live cases is not so well presented in that way, right? Because you thought through it already. Look at the height, look at the skirt, and you actually in your own head, you kind of know what you are doing in much greater detail than you presented. So I think again, the devil is really prepare these cases well and plan what you're doing and execute it. So I think you've done a great job. Yeah.
Thank you. I think a consecutive online and ever the lecture would be very the sum up our 2 live case demonstration. Thank you. Appreciate.
Thank you.
Thank you.
So yeah, go ahead.
We move on, right, Alan?
Yeah.
And after these 2 wonderful cases, it is really my pleasure, and I'm glad I can see him, even though we are now a little bit closer here in California, to see my dear friend Alan via video, and he's talking about something very important: optimal valve choice in various TAVR situations. And I know, he's one of the biggest experts in TAVR, so we're very much looking forward, Alan, to your presentation.
Thank you very much, Eberhard, and it's a pleasure to be among this esteemed panel to talk about a topic that is really, I would say, quite difficult and obviously can be controversial no matter which way you come up with. So the title obviously is, optimal valve choice in various TAVR and a complex equation to select one. So no questions, and several years ago, this topic could be even more complex because we have so many TAVR valves that we were thinking that it would come onto market, and then how do we choose them and so forth. But as it turns out in these sort of little circles that, the green ones is the FDA approved one, which is Evolut R and Pro, and then the Sapien system. And then obviously many of them are CE marked, but in reality in the US and different part of the world, we're pretty much talking about looking at Evolut systems and the Sapien system. We are testing the accurate neo at this point, and obviously, as Jen is talking about, there's JenaValve as well. Portico may be it, but pretty much the rest of, for example, in STAR here, the direct flow is no longer available. There should be a STAR in the Lotus Edge that's been withdrawn from market. So it's really this field is, even though there's a lot of designs, but to break through the testing, the clinical trials, and follow up in large numbers is a pretty big mountain to climb for many valves. So essentially, what I'm trying to focus on today, this evening, is talking about the selection of Evolut Pro versus SAPIEN 3, if you don't mind. So if you look at sort of randomized data, there's a lot of little studies, but I think the best one in the last couple of years is the SOLVE TAVR trials, which is a 2x2 randomized trial of self-expanding system versus balloon expandable system. And also they're testing general versus local anesthesia, which we'll not talk about today. So again, this is looking at how can we decide in a randomized way, are there differences between these two valve systems? So it's a 2x2 factorial, and we're talking about really the top half is that these are patients with symptomatic aortic stenosis randomized 1-to-1 to the Evolut R system and then to the SAPIEN 3 system. And then obviously there's further stratification according to local general anesthesia. I think this is a pretty well done study. It's about 450 patients, half to Evolut and half to SAPIEN. And most of them underwent the procedure of assignment. So that's good, meaning that there's only 2 crossover to SAPIEN 3 from the Evolut system. And there is actually 1 crossover to the core valve Evolut system on the other side. So pretty equivalent in terms of there's not a lot of mixing, which is a problem if you have these randomized, and then intention to treat versus treatment will be different. But here is pretty much the same. So 30 days endpoint as well as 1-year follow-up. Obviously, the loss to follow is relatively small. So that's, again, good that we have good data. So the bottom line is that you look at 30 days primary endpoint, depends on valve strategy, all-cause mortality, stroke, moderate or severe prosthetic valve regurgitation, and permanent pacemaker implantation at 30 days is really not very different. 28.4% for Evolut R and then 25.9% for SAPIEN 3. And essentially, the p-value for equivalency is 0.04, meaning that it does meet the equivalency parameter. If you look at the 1-year valve strategy, you can see that quickly the composite endpoints is not very different. The all-cause mortality is similar. Cardiac mortality is quite low, but SAPIEN 3 is a little higher here. And this is most likely due to the stroke that is unusually high in the SAPIEN 3 arm, which I will touch on briefly. And there's obviously moderate and severe PVL is a little lower in SAPIEN 3, but not different. Pacemaker implantation is still high in both arms at 1 year, at 20%, and then 24% in the Evolut system. Again, not super different. And time-related safety is pretty good on both sides. This is a 1-year outcome in valve strategy, and this is all-cause mortality on the left, and this is the confidence interval superimposed on top. So essentially, there's really no difference in all-cause mortality between the 2 valve systems. If you look at stroke, there is a significantly higher stroke rate risk in the SAPIEN system, and a lot of it is this during the initial pieces of the procedure. So you can see that there's within the first less than a month, pretty much in hospital, there's a big climb in stroke, and then probably flatten out, as well as a little late events as well. So this is kind of interesting. It could be a fluke because of just the patient population and so forth. But again, would balloon expandable actually send more material to the brain? And also the issue of leaflet thrombosis and so forth, could it be catching up later in years? So again, this is too small a trial to really be able to answer those questions, but it's an interesting observation. If you look at echocardiography, we're finding no surprise compared to all the other trials that if you look at the valve area, Evolut is generally a little higher. The p-value is close to significance. The index is not significant, but if you look at the mean aortic gradient, is 6 versus 10, and the p-value is significant, and the maximum also is significant as well. So Again, continue the same story, I'll probably give you a little bit better hemodynamics. So then, by and large, I would say the two valve system is equivalent. And as you see from the cases here today, in right hands, you can actually get very good results. And when you get good results, this trial also shows you that you can achieve similar composite endpoints of death, stroke, moderate to severe PVL, and pacemaker rates. And more strokes, as we talked about, and better hemodynamics in the self-expanding valve. The issue is that, when you try to select valve for your procedure, is really nuance driven. It's really not just sort of just on textbook in terms of thinking about which valve to use. So I'm just going to make a little equations, since this is the title of the talk. So this is the equation. And this is just a joke because obviously there's no such equation. But you can see that it's relatively complex. It's a summation of many different factors. And therefore, you really cannot necessarily have an equation to do this. So what I try to explain to my fellows and others as well is that when I choose valves between SAPIEN 3 or Evolut Pro, there are anatomical consideration, not absolute, but relative. So access site, for example, if you're talking about, close to 5 or sub 5, then obviously the Evolut Pro gives you some advantage on the inline sheath. If you're tortuous iliacs, the SAPIEN 3 sometimes have trouble as well because of tracking around with a stiff valve inside the sheath, and the Evolut Pro will have some advantage. And calcified iliacs is especially concerning sometimes with the balloon expandable because of the stiff valve going around, difficult to push, easy to tear the sheath, and therefore when you exit the sheath, it can tear the iliacs and causes major harm up to the iliacs and causes bleeding. So again, if you calcify tortuous iliac system, the Evolut Pro could be a better choice. Annular sizing, the SAPIEN 3 may have an advantage here, but again, it depends on fine points that it can actually go up to higher size, especially if you add 4 cc to the 29, while the Evolut Pro is divided parameter. So sometimes by area, generally Evolut Pro is a little smaller. So large valves, SAPIEN 3 may be the choice. The outflow tract calcium is a relative term. I try not to put it in a balloon expandable in a very calcified outflow tract, and therefore causes harm, potentially annular rupture and so forth. And the self-expanding may have an advantage there as well. In the past, septal bulge kind of sort of makes me think about not to put Evolut in there because it might pushes it out. But nowadays, our technique is pretty much high implant, and therefore the septal bulge is no longer really a major issue. Heavy valve calcification need predilatation in both system, but also the Evolut potentially you need to post dilatation as well. And continuing thinking about the differences in subsets rather than anatomical factors. So bicuspid, I think nowadays, given the right type of techniques and so forth, I would say that both system can do well in the bicuspid environment. Obviously, the outcome may not be as good as tricuspid because of perivalvular leak and potential other risks, but I wouldn't say that. I would say one valve system will be choice over the other. And Eberhard is going to talk about this further. Low risk, at least from clinical trial, looks like there is feasible in both. The concern I have is going forward in these younger patients with low risk, if there's need for a TAVR and TAVR down the road, are you more comfortable in putting a self-expanding valve in a balloon expandable valve? So use a SAPIEN 3 first to start, or you are more comfortable putting in actually a self-expanding or a balloon expandable in a self-expanding valve, meaning which way would be sort of going towards a strategy of TAVR forever, if you may. If the patient have a lot of AI, and especially if there's minimal calcification, I think the Evolut system may be better to stabilize the valve both at the annular level as well as the outflow tract aortic level. Coronary access, whether it's now or in the future, it could be quite more straightforward in the SAPIEN 3 because of the lower frame, but more difficult Evolut Pro system, though not impossible, as I will show. Valve in valve, I would say that I would generally like to have Evolut, but obviously larger valves in the SAPIEN 3 can do a great job as well in the larger surgical valves. Small annulus, I generally avoid 20 millimeters because the patients population we see generally are not as small and not as short as the first patient we have today. Therefore, generally, I like to have better hemodynamics, and therefore, generally like to have an Evolut system. Decreased LV function, as we illustrate in second case today. You try to avoid long pacing events, so therefore self-expanding may be a choice. Low flow, low gradient is a challenge because those patients will really need to have good hemodynamics. From my standpoint, is that maybe better again, self-expanding give you better hemodynamics, maybe a good choice. So again, I think these are subsets to think through in terms of what you think is will be fitting for your patient. This is just to touch on, I think, what Dong Wook has talked about already, the sort of the evolution, both in terms of valve, which is one obviously change over time, but also technique, because we in the past obviously implant the valve relatively deep, and therefore the self-expanding have a pretty high pacer rate. But obviously, as Hemel has shown, that you can do cusp overlap, and if you follow the sort of the system of starting high, allow the valve to descend rather than pulling back, and then you have control pacing so that there is really a stable withdrawal. And then obviously you can have really quickly check your cusp overlap view, and then also the left coronary view, knowing that the left side will probably kick up a little bit as you release the valve, and a slow and methodical release, and generally gives you a very good position. So what basically that showed is that you can actually now achieve a PPI rate post TAVR in the self-expanding valve at about 5.7%, which is quite remarkable. Used to be obviously double digit. So I think, again, depends on your major goal, whether it's to avoid pacemaker implantation or coronary obstruction. As illustrated in the second case today, you can adjust your technique to achieve the most worrisome complication that you don't want to avoid. You want to avoid. So about coronary access, again, this is based on Gilbert Tang's work, is that if you use a self-expanding stent, there's a pretty high chance of coronary access issue. So unfavorable coronary access, whether it is because it's below the skirt or it's because in front of the 3 TAVR commissural diamonds on the top here in yellow, or could be in the front of the commissural triangles. If you add it together, about 35% chance of 35% of the time, the left coronary will have difficult accessing, and about 25% of the time for the right coronary artery. Similarly, if you look at sort of the same way to plot it out, obviously because of the shorter frame and the open cell in the top, the unfavorable coronary access will be a little lower in the SAPIEN system. But in order to do that, again, nowadays there's a mitigating technique that, again, making the valve choices not as important anymore, is that if you use the 3 o'clock technique and also looking for the hat of the system, meaning the lower part that has done this asymmetrical radio opaque as a marker, so you can see whether it is on the outer curve or it's in the center front of the aorta, that you can actually now tune a little bit of how you actually position the self-expanding. Therefore, you can reduce the left main sort of difficult access from 30% or so to 14%, and the right coronary to about 11%. So both coronaries could be down from 14% to 5%. So again, I think it's important to understand that choosing valve is important, but again, choosing the right technique for each valve is also important as well to get you the best outcome. So I would say that in conclusion, really my equation is pretty simple, is that for the SAPIEN valve, you have to have experience with SAPIEN. So if you have lots of experience with the SAPIEN, you actually could do most of these sort of have all the patients with the SAPIEN valve. Just like Dr. S.J. Park has a small annulus, we thought you might need to have a self-expanding. Clearly, he achieved great results with the 20mm SAPIEN valve by selecting the right type of patients, the right technique, and implantation height and depth. Similarly, Evolut Pro, if you want to use that, is obviously you have a lot of experience with Evolut systems, because you need to tune that valve, how to put it in a way that achieve the best results and avoid complications, as John Wook has shown, that we always thought that you might need a smaller valve, use coronary obstruction, you might want to do a SAPIEN, but he's shown very expertly that he can do that difficult patient with the Evolut system as well. So my conclusion of this talk is that the equations are complex, but it's actually, once you have enough experience, it boils down to a relatively straightforward equation. It's really your experience of each valve system. Thank you very much.
Thank you very much, Alan. A great summary. And you covered, obviously, a very difficult question. And I I think we all agree with your final comments. Basically, it comes down to personal preference, personal experience, given the fact that both systems in essentially are having the same results all over. So thank you very much. And I guess now we have
you're giving the talk next, so I'm going to introduce you, Eberhard. Obviously, you don't need introduction in any part of the world, and therefore we look forward to your talk and talk about low-risk TAVR patients, and I think that's especially important in choosing the valve system. You change the title a little bit on novel implant techniques, okay?
Yeah. So yeah, well, the reason why I changed that is a little bit, a low implant technique might misleading the technique that we're focusing on, given the fact that this is actually a high implant and not a low implant. So what I would like to do is novel implant technique, what's different to what we had done so far. And I would like to take the next one here, which is actually my financial disclosure. And let me just change the, now we know that basically pacemaker rates are, particularly for the self-expanding system, as you put out, Alan, and we were working ever since we started this journey to reduce the pacemaker implant, because both systems were still higher with as compared to surgery, and particularly the self-expanding Evolut, and other systems as shown here, the higher implants rate as the SAPIEN 3. So we all know this picture, and it is very important that we understand. I don't want to go into the details, but we know the proximity of the conductive system with the membranous septum and the non-coronary cusp is basically essential. And once we know where these are coming together, implant depth has been the most common procedural factor in order to avoid rhythm conduction disturbances. And this is, ever since we started this, the most important part that we are focusing on. So the conventional implant view is here, the three cusp coplanar view. We're all familiar with that. And historically, it is an alignment of the three cusps between the left and the non in a coplanar view, because we thought it's the best one. I might actually, for those of you that have followed me, when I started with CoreValve, I started out RAO because I thought we had a better visualization of the membranous septum without really knowing too much about it. It was just my thought about this. And then, being a little bit closer to other centers and to Jean-Claude, we changed to LAO view. Basically, if you look at these three pictures, we know that the AV node, which is here shown in light blue, demonstrates the greater visual separation between the basal annular plane and the conductive system when you use the overlap view. It's foreshortened in the three cusp coplanar view, which is highlighted here in yellow. And the big arrow here points out to the separation, which I think it is important on a forward-going basis. Now, then we look the new technique for the controlled and precise and actually better implantation is the cusp overlap technique, which you can see here, which separates the non-coronary and then you try to overlap the right and the left. And here you can see it separates very nicely the AV node from the basal plane. And that is important because the cusp overlap actually elongates the left ventricular outflow tract, which is a better view for the implant. And now, briefly, but very important, I would like to point out the new technique. And this is important, the steps, because what we saw in the previous one, it is a little bit of a mixture between cusp overlap versus classic deployment. And the arch is being crossed in a normal way, and then you change the image projection to do predetermined cusp overlap view on pre-procedural CT planning. And that is classic LAO, but in the cusp overlap technique. For the most part, it is RAO. You change to RAO. It's strange that, when we started this out, at least from my point of view, I did it without really knowing what I was doing, I guess. Position system with the catheter marker band, and that's an important thing that we have to point out, should start at the midpoint of the pigtail catheter, and then you begin a slow deployment. The reason why you start high, which we traditionally thought was too high, but now with a better separation and visualization of the annulus, we know it's not too high. Then we start deploying the valve. And this is very important. What we try to do now, starting with the marker band in the mid pigtail, is to let the valve come down instead of pulling it up. That's a big difference because, as we know, once the valve flares, it might actually interact with the membranous septum and the conductive tissue. So instead of going in and pulling up, which might scratch the conductive system, we start high and let the valve come down. So that's an important difference between the classic view and the cusp overlap technique. And then, as a matter of fact, the Lunderquist is the recommended wire in order to move forward. Now, some clinical data, once we've seen this, don't want to go into too many details. The Optimize Pro study is a study that investigated the outcome associated with utilizing the cusp overlap technique during valve deployment, the new technique, as well as pre and post-procedural TAVR care pathways centered on safety and early discharge. When I was in Korea and proctored, one of the main objections was from SJ, the high pacemaker rate, and that he has to keep the patient in the hospital longer than the SAPIEN. This is addressed in the Optimize Pro study. And you can see here, apart from the primary endpoint, the secondary endpoint is days from index procedure to discharge, non-trace AR, and discharge rate of pacemaker implant for new onset of worsening conduction disturbances at 30 days. So it's addressing exactly the issue that SJ raised. So here are some patient characteristics. You can see here STS in this study. Roll-in 71 patients, main cohort for intermediate analysis, 100 patients, STS 2.9, low risk, and then pre-existing right bundle branch block 5.7, combined 6.0, and pre-existing PPI and ICD 0 for both. Procedural outcomes worthwhile to be mentioned. The Lunderquist in more than half, actually combined 65, initially 55 and 73%. Pre-balloon valvuloplasty in half of the patient. Post-dilatation in this system, fairly impressive, 13% only. If you ask the general population today, they would tell you definitely there was more post-dilatation. Implant depth and the non-coronary is actually 3.3%, which is what we're trying to aim at. And here are the procedural outcomes, the number of valves, no double valve, no EKG changes in half of the patients, and step-down floor telemetry unit, very, very high, 78%, which is going into the right direction, that these patients don't have to be monitored. And this is a 30-day outcome, all-cause mortality, excellent, no deaths, no disabling stroke, and the single-digit pacemaker implant, 8.8% for the combined cohort, 7% in the roll-ins, and 10% for the main cohort, combined 8.8. So definitely there is something important here with the cusp overlay technique. And interesting, and some of you might recall when I started the non-pre-dilatation journey, that was a time when I was in Brazil. Basically the same thing happened here with Hamad when he was in Latin America. Some of these things are starting in Latin America because other people think you're crazy. As you know, when I did this non-pre-dilatation thing, they thought I was crazy. So I started in Brazil. And you can see here, effective pacemaker rate with in Latin America and in Europe, 5.7% single digit, and also the event of new left bundle branch block with a cusp overlap, 4.9% versus 18.6%, quite a dramatic difference. And if we look at some centers in Europe, you can see here 30-day PPI rate using that particular technique with the overlay, with the Evolut platform, also low numbers of pacemaker rate. So there is definitely a difference. Coming to the end, answering the question, what in fact is different? What's different with the cusp overlap view and technique? Overlap the right and left cusps with isolation of the non-coronary, as I said before. With the Evolut platform valves, the new procedural approach includes starting a slow valve deployment with a marker band at the midpoint of the pigtail catheter, as well as the use of a stiff Lunderquist wire. What's different with outcomes? Basically, as I hope to point out to you, the low rate of new onset conduction disturbances and pacemaker implant rate, basically down to 8.8 or 4.9% LBB. The reason for that is that we start high and let the valve go down, exactly the opposite of what we used to do, going in and then pull up in order to leave the membranous septum and the conductive system alone. And another summary here, as TAVR continues to expand to younger, lower risk patients, obviously that is important because we try to avoid persistent conduction disturbances. So in all, the cusp overlap technique, the new deployment technique, is safe and effective at providing a controlled, precise placement of that valve. With that, thank you very much for your attention, and thanks for having me again at AP Valve and Virtual Structural Heart. Thank you so much.
Thank you, Eberhard. And I think time is a bit short, and if there's any comment from our discussant, please go ahead. Make any comments or questions?
What you should not do, if I may comment my own talk, what you should not do is you start overlap and then do the classic deployment.
Yeah.
That really doesn't make much sense. So if you do that, you have to have the courage, understand it, go high and let the valve come down instead of pulling it up again.
We actually are combining this cusp overlap technique, which Eberhard beautifully showed, together with pre-procedural membranous septum measurement, which enables us to even lower the pacemaker rate. Just a quick comment.
Yeah, it's down. I saw that it's down to 3% actually if you measure the membranous septum, right? Yeah.
I think it's important to conclude is that, choosing valves is only one piece of the whole strategy, right? Because if you choose the right valve but use the wrong technique, you still could be getting bad outcome. So therefore, when I think the top two combined together is that you have to pick the right valve, but do it the right technique as well for each valve as we learn more how to do these valves. So I think that's a very important lesson that we hope that our audience will have a chance to sort of observe through the two live cases and the two lectures. So I would like to conclude. So thank you so much, everyone, for contributing to this session. And I sincerely hope this is the last time we do Zoom together, even though I like to see everybody on the screen, but hopefully we'll see you all live in real person and have a cup of coffee or a cup of wine with all of you in the upcoming meetings soon. Thank you so much.
Thank you very much. Goodbye and stay well.
Have a great day. Thanks.
Bye.
Thank you.